Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove handy and useful in your line of duty. Welcome to part 76 of our Pharmacotherapy MCQ series, which measures in toxicology. The first question reads, which phase or phases of the nodal action potential is or are primarily affected by the two commonly used non-dihydropyridine calcium channel blockers, which are verapamil and diltiazem? Is it phase 3, 0, 1, or 2? I'll give you 10 seconds to choose the correct answer. They both affect phase 0. Now, diltiazem and verapamil primarily inhibit or slow down phase 0 of the nodal action potential, thereby reducing dromotropy. It is important to consider this in case of overdose by these two calcium channel blockers. Now, this is different from the potential in the ventricular myocytes. I would like to add that beta blockers and, to a smaller extent, diltiazem and verapamil inhibit phase 4 of the nodal action potential, thereby reducing chronotropy. That's just a by the way. Then I would like to remind you that diltiazem and verapamil inhibit phase 0. I'd just like to re-emphasize they inhibit phase 0 of the nodal action potential by reducing the movement of calcium inside the cell. Now, the phases within the action potential for nodal cell aren't the same as for those of the ventricular myocytes. Note that, which is why nodal cells, which are the SA and the AV cells, are pacemakers while the others are not. I would also like to emphasize that phases 1 and 2 aren't present in the SA node, whereas they are in the action potential of the ventricular myocyte. So note that major difference between the two. Now, beta blockers mainly, and to some extent calcium channel blockers, affect phase 4 by reducing the movement of sodium inside the cell, and this depresses automaticity of both the SA and the AV nodes. Let's move to the next question, please. And it reads, which of the phases listed below is affected by beta blockers? Is it phase 4, phase 0, phase 1, or phase 2? I'll give you 10 seconds to choose the correct answer. The beta blockers affect phase 4. I would like to start by saying that sodium bicarbonate may be effective in beta blocker toxicity where the patients have wide QRS intervals. Now, the non-dihydropyridine calcium channel blockers, just to deviate a bit, affect phase 4 by reducing the movement of sodium into the cell, and that depresses automaticity of the SA and AV nodes. So those are just by the way. Let's move to the next question, please. And it reads, which of the beta blockers listed below would be effectively removed by hemodialysis in the case of an overdose or toxicity? Would it be labetalol, carvedilol, nadolol, or metoprolol? I'll give you 10 seconds to choose the correct answer. Those three, nadolol is highly dialysable. Now, I would like to start by saying that hydrophilic beta blockers are more likely to be removed by hemodialysis. And atenolol and nadolol are hydrophilic beta blockers which can be removed by this method, hemodialysis. On the other hand, carvedilol and labetalol are mixed beta blockers which are lipophilic. So dialysis has no major role in their elimination from the body. And then metoprolol is a beta-1 selective blocker which is also lipophilic, and that makes answers A, B, and D wrong. They are not highly dialysable, unlike the lipophilic one, which is the hydrophilic one, which is nadolol. Let's move to the next slide, please. And it reads, in which of the acute medical conditions listed below can hydroxylated cobalamin be administered? Is it tetanus toxin? Is it ethylene glycol intoxication? Is it cyanide toxicity, or acetaminophen or paracetamol overdose? I'll give you 10 seconds to choose the correct answer. Cyanide toxicity it is. Now, hydroxycobalamin is the precursor to vitamin B12, which is cyanocobalamin, and it is marketed as Cyanokit, which is approved for the treatment of cyanide toxicity. Now, each molecule of hydroxycobalamin can bind to one cyanide molecule. Now, in doing so, the hydroxo group is removed, and cyanocobalamin, which is vitamin B12, is formed. It's better, or a better antidote for cyanide toxicity than amyl nitrite, sodium nitrate, and sodium thiosulfate, which have been historically used in the past. However, it's more difficult to administer and to monitor and to manage. So, for simplicity's sake, you're better off using the trio of amyl nitrite, sodium nitrate, and sodium thiosulfate, just as a by the way. Let's move to the next question, please. And it reads, which of the statements listed below most accurately describes the mechanism of action of glucagon when administered for the management of calcium channel blocker toxicity? Is it true that it promotes glucose uptake and carbohydrate metabolism to generate energy during myocardial stress, or does it bypass normal catecholamine generated influences on cyclic AMP and increases cyclic AMP via other mechanisms, which has been shown to increase pulse and blood pressure? Or is it true that it increases cytosolic calcium concentrations, thus improving inotropy? Or does it increase sodium uptake through the nodal cells? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. I'd like to start by saying that glucagon may bypass normal catecholamine generated influences on cyclic AMP, and it also increases cyclic AMP via other mechanisms which have been shown to increase pulse and blood pressure in calcium channel blocker toxicity. Remember, they cause severe hypotension. Now, beneficial effects of using insulin plus dextrose have been seen in calcium channel blocker toxicity due to the fact that insulin promotes glucose uptake and carbohydrate metabolism to generate energy during myocardial stress. And then sodium bicarbonate may increase sodium uptake through nodal cells. And when using glucagon, we should remember to premedicate patients with an antiemetic, since glucagon can cause the risk of nausea and vomiting, so be very careful. And I would just like to mention as a by the way that lipid emulsion therapy has 3 proposed mechanisms in calcium channel blocker toxicity. That is the encouragement of fatty acid transport across the mitochondrial membrane to improve energy production in the cardiac myocytes, and the second is a potential increase in cytosolic calcium concentration, thus improving ionotropy, and then the third is creation of what we call a lipid sink, where lipophilic drugs are more likely to distribute into instead of tissue. So those just additional facts that could help you manage such patients. Let's move to the next question, please, which reads, Master GML, a 19-year-old boy, is rushed to your accident and emergency department by his mother. She informs the emergency medicine consultant on call that this young man, GML, swallowed many of his tofranil tablets, and he is currently actively seizing. So my question to you is, what would be the next best course of action in Master GML's management? Would you check his drug levels? Would you check glucose levels in the serum or in the blood? Would you administer IV diazepam, or would you choose to infuse phenytoin? I'll give you 10 seconds to choose the correct answer. I would choose to check his glucose levels in the blood. I would like to start by saying that tofranil or imipramine is a tricyclic antidepressant, and there are a number of critically important interventions required in patients presenting with this initial information, and they include, but aren't limited to, for example, getting other vital signs, starting an IV infusion, getting some basic screening labs, and or preparing medication to administer for seizures. Now, ruling out hypoglycemia is not only easy to do, but it's also easy to treat and wouldn't respond to other traditional treatments of seizures. So if you missed out that, you'd miss out a very crucial element. Now, since phenytoin and fosphenytoin can also inhibit sodium channels in the cardiac muscles just like they can in the CNS, I would like to caution you never to administer phenytoin or fosphenytoin in tricyclic antidepressant toxicity, as they can worsen the risk of developing a cardiac arrhythmia in patients who have overdosed the TCAs. Now, diazepam is a good treatment option for seizures involving toxicity of substances, but hypoglycemia should be ruled out first, because it could be the reason the patient is seizing. It also takes a short duration to assess hypoglycemia. Then I would like to emphasize that administering benzodiazepine to a hypoglycemic patient will not manage his or her seizures, as glucose must be administered first. I would like to remind you that imipramine or tofranil is a tricyclic antidepressant with moderate conduction problems and high anticholinergic effects and even sedation. So key treatment goals in this case should be to get the QRS to below 100 milliseconds and to maintain the pH between 7.45 and 7.55, and of course to check the glucose levels before choosing other modalities of interventions. All those many words make me biased towards B, checking glucose levels. Let's move to the next question, please. And it reads, Master PLT, a 5-year-old child, is rushed to your accidental emergency department following an accidental overdose of sulfonylurea belonging to his uncle. My question to you is, which of the IV solutions listed below would be the most ideal to infuse in this clinical scenario? Would it be 50% dextrose in water, 25% dextrose in water, 5% dextrose in water, or 10% dextrose in water? I'll give you 10 seconds to choose the correct solution. I would infuse 25% dextrose because dextrose 25% is recommended in children. Now, for the management of hypoglycemia from sulfonylureas, IV dextrose should be infused at a dose of 0.5 to 1 gram per kilo IV start. Now, just like to add that 10% dextrose is recommended in the neonates, and 50% dextrose is recommended in adults, and it provides 25 grams of dextrose since the pack size is 50 ml. Let's move to the next question, please. And it reads, Mrs. TCC, a 35-year-old female, is currently admitted to your general medical ward for abdominal pain. Further investigations revealed that Mrs. TCC had an upper respiratory tract infection which she managed with several forms of acetaminophen. Your rough estimation in the course of doing a review of her medication history reveals that for 3 days she exceeded the daily recommended dose of acetaminophen. 20 hours have now elapsed since her last dose of any form of acetaminophen or paracetamol, and her next acetaminophen level or paracetamol level is 34. The AST is 121. So my question to you is, which of the treatment options listed below would be the most appropriate for Mrs. TCC now? Would it be N-acetylcysteine at a dose of 70 milligrams per kilo IV infused over 60 minutes? Or would it be N-acetylcysteine at a dose of 150 milligrams per kilo administered orally start? Or would it be N-acetylcysteine administered at a dose of 150 milligrams per kilo IV over 60 minutes? Or would you choose to administer 4 milligrams of ondansetron IV start? I'll give you 10 seconds to choose the correct answer. I would infuse N-acetylcysteine at a dose of 150 milligrams per kilo over 60 minutes in dextrose 5%. Now, for repeated supratherapeutic injection of acetaminophen, which is indirectly chronic toxication or chronic toxicity, the Rumac Matthew nomogram isn't very useful in determining antidotal therapy. Now, in this case, assessment of acetaminophen levels and AST surrogates for the remaining NAPQI and potential for hepatotoxicity is done. It is generally accepted that if the acetaminophen level is greater than 10 with AST elevation, then N-acetylcysteine treatment should be initiated. Now, the route of N-acetylcysteine is controversial in this scenario, but either the IV or the oral route may be reasonable in my opinion. However, with the above options, the only correct dose route combination is 150 milligrams per kilo IV over an hour. Now, acetaminophen indirectly inhibits prostaglandin H2 by blocking the heme on the peroxidase portion of this particular prostaglandin. That's just a by the way for your information. Let's move to the next question. And it reads, Mr. SSS, a 50-year-old male patient, is rushed to your accident and emergency department by his colleague who witnessed him ingest a handful of paracetamol tablets 6 hours ago. Mark the number 6. Currently, Mr. SSS acetaminophen plasma concentration is 140 mics per ml, and it is within the 2 lines in the Rumack-Matthew nomogram line. So my question to you is, which of the treatment options listed below would you recommend for Mr. SSS's management? Is it true that we should not administer IV N-acetylcysteine at this stage? Or is it true that we should administer N-acetylcysteine via IV infusion? Or should we opt to use the oral route? Or should we administer it via nebulization? I'll give you 10 seconds to choose the correct answer. I would infuse N-acetylcysteine via the IV route. Now, altered mental status should prompt us to use IV formulations, and I would like to add that N-acetylcysteine via nebulization is an alternative formulation which could be considered if the patient can't tolerate both oral and IV formulations. Now, oral N-acetylcysteine, on the other hand, should be diluted with soda to mask its bad taste and smell, because it would easily trigger vomiting and complicate issues for us in this emergency. And then acetaminophen plasma concentrations within the nomogram line indicates possible hepatic toxicity, and treatment with N-acetylcysteine should therefore be considered, in my opinion. And I would like to add and remind you that anaphylactoid reactions have been reported with IV N-acetylcysteine, more commonly in the pediatric patients, and use with caution in this patient population must be considered, especially those with moderate to severe asthma or with a history of bronchospasm. So in the pediatric population, be very careful when you're infusing N-acetylcysteine. That's just a by the way. Let's move to the next slide, please. And the question reads, WDJ, a 4-year-old child, is rushed to the accident and emergency department by his hypertensive mother following an accidental overdose with her unattended antihypertensive drugs, which this young fellow found in the mother's pill box. She is unsure which of her antihypertensive drugs the young fellow ingested. So my question to you is, which of the physiological states listed below would help differentiate beta blocker toxicity from calcium channel blocker toxicity? Would it be hyperglycemia, bradycardia, hypoglycemia, or would it be hypotension? I'll give you 10 seconds to choose the correct answer. I would use hypoglycemia to differentiate the two. Now, a potential differentiator of beta blocker from calcium channel toxicity is hypoglycemia, because beta blockers can inhibit glycogenosis and gluconeogenesis, which calcium channel blockers on the other hand, may result in the opposite. Now, the toxicological effects of calcium channel blockers are bradycardia, hypotension, with or without hyperglycemia. Yeah, so they don't cause hypoglycemia at all. They can cause hyperglycemia. So if hypoglycemia occurs, then I would rule out calcium channel blocker toxicity and settle for beta blocker toxicity. Let's move to the next question. And it reads, Mrs. LWA, a 36-year-old female patient, is receiving a sodium bicarbonate infusion at a dose of 1 milliequivalent per kilo per hour following an amitriptyline overdose. Currently, she is under observation in your accident and emergency department, and she remains awake. She is cooperative. So my question to you is, which of the monitoring parameters listed below would be the most appropriate to use in this clinical scenario now? Would you use urine ketones, serum potassium, PaCO2, or serum creatinine? I'll give you 10 seconds to choose the correct answer. I would monitor serum potassium. Now, the management or the treatment of tricyclic antidepressant overdose aims to narrow the QRS interval to improve hypotension and to target a blood pH of a narrow range of 7.0 to 7.55. This is achieved by administering sodium bicarbonate, to be specific. Now, the doses of sodium bicarbonate required to achieve this will likely cause urinary potassium wasting, and that would cause hypokalemia, which would be very dangerous. Now, therefore, sodium concentrations in the serum must therefore be monitored closely to avoid consequences such as, for example, QT prolongation and even tossade de points, which are more likely to occur with hypokalemia. I would like to emphasize that serum creatinine, urinary ketones, and even PaCO2 may be followed up, but they don't play a major role in the monitoring of this therapy. Now, in clinical conditions such as tricyclic antidepressant overdose, or in aspirin overdose, or in diabetic ketoacidosis, which may require large doses of sodium bicarb, the serum potassium levels must be closely followed to avoid hypokalemia resulting in arrhythmias. Now, the goal of therapy for tricyclic antidepressant toxicity or overdose is not urinary alkalinization as such, but rather narrowing of the QRS interval. I'd like to remind you that urinary alkalinization doesn't enhance, and it may reduce urinary clearance due to passive reabsorption of an ionized tricyclic from an alkaline urine, and that could be very dangerous. Now, the TCAs primarily exert a sodium channel blocking activity in overdose, and they can mimic the electrocardiologic effects of the Vaughan Williams class 1 antiarrhythmics. Just as a by the way, so B would be our right answer here. Let's move to the next question, please. The next question reads, a concerned mother of a 9-year-old girl rushes the daughter to your accident and emergency department, and this mother tells the emergency medicine consultant on duty that something isn't right with her daughter. In her own words, this daughter is irritable, though lethargic and inconsolable. So my question to you is, what should the consultant initially assess? Is it liver function tests, blood glucose levels? Should he do a urinalysis or a throat swab? I'll give you 10 seconds to choose the correct answer. He should monitor blood glucose levels. Now, I'd like to start by saying that lethargy and irritability should prompt a clinician to check the pediatric patient's glucose levels in almost any presentation where the child is lethargic. Now, the clinical presentation of sulfonylurea toxicity has generally non-specific signs and symptoms. However, lethargy and a change in mental status prompts the need for blood glucose level checks or even tests. Now, I would like to add that sulfonylurea or ureas as a group increase insulin secretion, thereby causing hypoglycemia, and that is a major concern with this class of drugs. Now, hypoglycemia from the sulfonylurea toxicity typically occurs 8 to 12 hours after ingestion and may even be delayed to 24 hours. So there you have it. That brings us to the end of this video. And if this video benefited you in any way, I would like to humbly urge you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration, and I look forward to interacting with you in the next video. Thank you very much.